right, we can get started. Welcome, everyone. Thank you for joining us for Civics Data to Drive Decisions. Today, we're going to be looking at best practices and challenges in addressing low-value care. My name is Kristen Paulson. I am the CEO over here at Civic, and I will be taking you through the day. Oops, there we go. Our presenters today are myself, in order of appearance, myself, Tim Janader, our lead healthcare data analyst, and Emma Anderson, our lead healthcare reporting analyst, as well as Dr. Lalit Bajaj from Children's Hospital, Colorado. For those of you not familiar with Civic, we are an independent nonprofit. We are nonpartisan and objective, and our mission is to equip our partners and communities in Colorado and across the nation with the resources, services, and unbiased data needed to improve health and healthcare. Our vision is that everyone will have the opportunity to be healthy and will have access to equitable, affordable, and high-quality healthcare. We serve change agents across the state. Here at Civic, we consider a change agent to be anyone who is working to lower costs, improve care, and make Colorado healthier. That includes a number of different kinds of organizations and individuals, including hospitals, employers, health plans, researchers, the state government, but most of all, we like to make sure that we keep consumers front and center in the work that we do. So how do we do that? There are a number of ways that we serve the state of Colorado and help move healthcare forward. We are the administrator of the Colorado All-Payer Claims Database through a designation from the state of Colorado. Through that designation and the work of our staff, we provide a number of different kinds of public APCD data. This takes the form of our public reporting on our website through those interactive reports, white papers, and other publications, as well as downloadable data sets that are available through the website. We also have non-public data available for researchers or other individuals looking for custom views of our data or to have a specific kind of report or resource created for them. We've also recently built out our capabilities around research and program evaluation, community engagement, and we do have internally initiated program areas that are focused on advanced care planning, palliative care, and aging adults. So what is in this Colorado APCD? A brief overview of what that contains. We recently hit 1 billion claims in the APCD starting in 2013 all the way through 2022, and every month that continues to grow. We cover over 70% of the insured lives in the state of Colorado. And for 2021, that means 5.5 million lives within the state of Colorado. We have well over 40 commercial payers, plus Medicaid and Medicare, fee-for-service and Medicare Advantage. And we also have comprehensive trend information on what we're seeing as far as coverage in the state of Colorado available on the website. There are a couple important pieces of information that are not in the Colorado APCD. One of those is folks covered by the federal programs. So the Veterans Administration, TRICARE, the Federal Employee Health Benefits Program, or Indian Health Services. We also don't have information on those without insurance, so the uninsured individuals in Colorado and those who self-pay for their services. Finally, we are missing a number of the ERISA-covered self-funded employers and the lives associated with those plans across the state of Colorado. But we estimate, again, that our database covers over 70% of the covered lives in Colorado. So we're able to talk about what is going on across insurance programs and the individuals who are in the state. I'm now going to turn this over to Tim Janader, who's going to walk us through what we're calling low value care and really build a framework for the conversation we're going to have today. Tim?
Thanks, Kristen. As Kristen mentioned, my name is Tim Janader. I'm a senior healthcare data analyst at Civic. And today I'm going to be discussing our analysis of low value care using the data from the Colorado All Payers Claims Database. So to start, we define medical care to be low value when the potential harm or cost to the patient is greater than any expected benefit. And going back to 2012, the American Board of the Internal Medicine Foundation launched what's called the Choosing Wisely campaign, asking medical specialty societies and practicing physicians to identify tests or procedures commonly used in their field whose necessity should be questioned. And today there are more than 550 of these Choosing Wisely guidelines. A survey of physicians suggests that several factors contribute to the delivery of this low-value care, including defensive medicine due to fear of malpractice, perception that patients want or expect diagnostic tests or medication, lack of information regarding the patient's medical history or inadequate time to spend with the patient, and also financial incentives or conflicts of interests. A 2019 study published in the Journal of the American Medical Association estimates that approximately 25% of healthcare spending is potentially wasteful and spent on services that don't make us any healthier. The reduction of low-value care, therefore, is appealing because it would lead to billions of dollars of savings and lead to improvements in quality of care and overall health. Next slide. Yeah, there we go. The data we have to analyze comes from the Colorado All-Payer Claims Database. It includes commercial, Medicaid, and Medicare data with service dates from 2017 through 2021. It is processed through Milliman's MedInsight HealthWise calculator, which identifies 58 instances of low-value care that can be derived using claims data. Here are 4 examples of the measures that are included in this analysis. First is these pediatric head CT scans, which have a low diagnostic yield and a high potential risk of ionizing radiation or associated cancer risks. Next is imaging tests for eye disease. Choosing Wisely calls these unnecessary for patients without symptoms or signs of significant disease pathology because comprehensive history and physical examination will usually reveal if eye disease is present or getting worse. The next is cardiac stress testing. For this advanced non-invasive imaging in the initial evaluation of patients without cardiac symptoms is unnecessary and wasteful unless high-risk markers are present. And finally, for asymptomatic adults without a chronic medical condition or other health concern, routine general health checks with a comprehensive physical exam and lab testing is considered unnecessary. We recognize that this measure in particular is controversial, as many believe that maintaining a relationship with a medical provider is necessary for general good health. However, it is a Choosing Wisely guideline and therefore is included in this analysis. All right, now I'll walk through some key points on how we use the data and our reporting methods. First, only patients with sufficient claims history to accurately determine wastefulness are included. The 58 measures that can be derived using claims data are classified into 3 degrees of patient harm, low, medium, or high, depending on their long-term effects or their propensity for cascading medical events or costs. And finally, these medical services are grouped into 4 categories. There's wasteful, likely wasteful, necessary, and optimal. For our purposes, we grouped wasteful and likely wasteful together and consider that low-value care. Necessary services mean that a low-value service was identified, but the care was ultimately clinically appropriate and therefore not low value. And finally, optimal services are those administered in accordance with the best practice guidelines. So here's an example of one of the 58 measures and how it can be broken out into those 4 categories. So as stated before, imaging tests for eye disease is unnecessary for patients without symptoms or signs of significant disease pathology. The tests themselves are not necessarily harmful, so there is little to no physical harm of performing these tests on patients without signs of disease. However, it is considered low value because the cost of performing these tests is not worth any potential benefits to the patient. A patient would be categorized as receiving optimal service if they have a claim with a diagnosis of eye disease without a service for advanced eye imaging within 1 year. A necessary service would then be a patient with a claim for advanced eye imaging who also had a specialty code for an ophthalmologist or optometrist visit within 30 days prior to the imaging. And then a low value service would be a patient with this advanced eye imaging and no prior specialty visit. I'm now gonna pass it off to Emma, who's gonna give a overview of our interactive report.
Thank you, Tim. Kristen, I believe if you could stop sharing your screen. Thank you. Okay, as Tim introduced, my name is Emma Anderson. I am a lead reporting analyst at CIVHC, and I build a lot of the interactive public-facing reports that you'll see on our website, which is what I'm going to walk through today. I believe we will be sending out the link to get directly to this page in our follow-up email to this webinar. But first, just so you know how to navigate here, if you go to our website, up here, you'll see Get Data, and it's under our Public Data section. And it's actually in a focus area called the Affordability Dashboard. So this specific low value care report is couched currently in a larger report called the Affordability Dashboard, which encompasses several topics related to healthcare cost drivers. So when you get to the report, you'll just see that low value care is a specific tab that you'll click on here. I also did check with several search engines, and if you type in CIVHC low value care, it'll be the first non-ad based result that'll come up. But we will send out that link. So this tool derived from the data and the methodology that Tim already started to explain really helps you drill down and dig into this topic. First, right here at the top, we do have direct links to a very detailed methodology write-up, which Tim is already giving a wonderful overview of, but if you want to get into the nitty-gritty, we get that for you right there. Then the next section, we have some global dashboard filters. So these are the different payer types that you can drill down into. You can see the different options we have here. If you want to look at different years, we have a lot of historical data, and we can hone in on specific division of insurance regions as well, so different geographies. And these filters will apply throughout the rest of the report. So you can really drill down to try and answer specific questions that you have, to see specific areas that you'd like to look at, et cetera. Below the global dashboard filters, right away is just a key summary of the main metrics. So you can see what low value care looks like for your selections. I'm looking at all payer types here for the most recent year of data we have, 2021, and statewide. I've selected all regions. And then we can see what was the total volume of low value care services, what was the total costs, and that average cost per low value service. You'll see throughout the report, there's some icons that just help define exactly what every metric is. Hopefully they're mostly self-explanatory, but if you want that extra detail. Digging in a little bit deeper, we start looking at trends over time for these low value care services and costs. So you can see not only how low value costs track with the volume of low value services. You can see that here, and if you hover over, you can get that really fine detailed numbers. You can also see of those 58 potential low value services that were identified, how many of those services, what percent actually did end up being low value. So you can see that here. Another thing to point out, because I know these global dashboard filters are at the top, they do apply all the way down. In every section, we do have some breadcrumbs here, so you can remind yourself of what your selections are. So for example, if I'm just looking at Denver it'll remind you right here that this graph you're looking at is just Denver. Then we get even more detailed. We start to look at geographical variations. We're using Division of Insurance regions here, so pretty big land areas, but we can still see how this looks across the state. And here you can see the average cost per low value service, both in map form, so you can really see kind of a snapshot of it across the state. And then we rank the Division of Insurance regions over here as well, so you can see where the costs are really high or relatively low across the state. And again, with the map, you can hover over and see a little bit more information. And then lastly, the most detailed section is looking at the specific service types or procedure types. So this graph, you'll see the top services or procedures, and you can choose based on either total low value spending or just the average cost per that service, a low value service. So for example, just for renal artery revascularization, the average cost of a low value service is over $9,000. And then you can also see just for that specific procedure that 97% of that procedure was considered low value. 97% of the time that it was performed, it was considered low value. So you start to get down to the most detailed level here by being able to look at specific services and seeing how often they're low value and what the costs and the consequences of that are. As Tim mentioned, our methodology also identifies the risk of harm to the patient, the potential risk of harm. So we have color-coded based off of that metric as well. So your eyes should immediately go to the scary orange procedures and services, because not only is that raising costs, but potentially harmful to the patient, so lowering quality of care as well. So lots of ability to, I know I went over that very quickly, but lots of ability to play around, to get interactive, to hopefully answer very specific questions you might have on this topic. And like I said, the link will be sent out, but this will be on our website for anybody who needs. Okay, I'm going to pass it back to Tim.
Yeah, thanks, Emma. That's a really great overview. I'm going to go briefly through some of the findings, the higher level findings from this analysis that we found most interesting, all of which can be found on that interactive report that Emma just showed. So this slide shows the top 5 services by spending in 2021. And as we can see, the most expensive low-value care service by far was this inappropriate opioid prescriptions. And the top 5 is then rounded out by screening for vitamin deficiency, prostate cancer screening, imaging tests for eye disease, and coronary angiographies. This slide then shows the 18 services that account for over 85% of the low-value spending and services throughout the state in 2021. What is interesting to note here is that cost per service on the left-hand side of the graph. It ranges from the cheapest cost per service at routine general health checks at about $29 per service, all the way up to the most expensive, which is coronary angiographies at nearly $8,800 per service. This shows that low-value care can be expensive due to a lot of lower cost services adding up, or even a few of these higher cost services. Here we see the trend in low-value care spending from 2017 to 2021. This is for all payers throughout the state. And overall, in these 5 years, we see that the spending has decreased by about $20 million. And then, as Emma showed in the interactive report, these are results by division of insurance rating regions. These maps show both the percentage of spending that is low value and the low value index, which is the ratio of low value services to all services. And for both measures, we see that the Pueblo region has the highest index, while the Boulder and Fort Collins regions have the lowest. This map shows the average cost per low value service by the DLI regions as well. And we see that it ranges from $65 in Denver up to about $97 per service in the West region. And finally, this last chart displays the top 3 low value services by spending for each payer type. As we can see, there are not many commonalities. For example, routine general health checks are pretty much concentrated in the commercial population, while prostate cancer screening is mostly in the Medicare fee-for-service population. And this shows that the differences in the populations that are insured by these payer types really drive the services that are being received. As I stated previously, the reduction of low-value care is important to both reducing costs and improving quality of care overall. This analysis is applicable to many groups, including providers, policymakers, payers, and even healthcare consumers. And each group has the ability to affect change and ultimately reduce low-value care. And I'll pass it back to Kristen to introduce our next speaker.
Thank you, Tim and Emma. It's really a great overview. I'd like to introduce Dr. Lalit Bajaj. Dr. Bajaj is currently a professor of pediatrics and emergency medicine at the University of Colorado School of Medicine, Children's Hospital, and is the Chief Quality, Equity, and Outcomes Officer for Children's as well. Dr. Bajaj focuses on clinical effectiveness, patient safety and equity, and ultimately driving value-based care for our most vulnerable patients. Dr. Bajaj?
Thank you so much for having me, and thank you for investing in this work. This is, I think, a really important and complex topic, and I'm excited to be here today. We can go to the next slide. So what I'm going to focus on today are strategies that we have taken here at Children's Hospital to look at low-value care and what we do to create programs to decrease low-value care. And I'm going to hopefully highlight a few of the things that have been mentioned around what are some of the challenges that we have as a practice, as an institution, to get to the right care at the right time, and look at some of our outcomes, and hopefully we can have a good discussion about it. Next slide. So I think it's important to remember that when we look at implementing a new program, oftentimes in the case of low value care, we're trying to de-implement. And evidence has shown that about 30 to 40% of patients don't get proven treatments, and about 20 to 25% of patients get care that is not only not needed, but potentially harmful, that like we discussed. Next slide. So I began this work many years ago, and then worked with the organization to create a Department of Clinical Effectiveness. And this is our mission and our vision, certainly broad and very ambitious, to empower extraordinary care through information, insight, and action, and to partner to inspire and serve our community in delivering the best value care for kids. And we were very deliberate about using that word, best value care. The next slide, please. This is the way we work in terms of our improvement teams. We work with clinical experts. We combine that with data and analytics, and we partner with process improvement and continually reevaluate the evidence in order for us to create that triad of expertise, data, and process improvement. For many years, I think what we were asking people to do was to follow evidence, the clinical experts' design, in the absence of timely data, and in the absence of a structured way to actually get the work done. The aspect of evidence into practice, we know it takes about 17 years, but on the flip side, to de-implement probably even takes longer. We are really good at adopting certain things, a new test, a new treatment, but oftentimes when we do that, we've done that in the absence of rigorous data, and then we find ourselves in a position where we're practicing what we think is evidence-based care, but we haven't reevaluated its value. So you'll see the word partner quite a bit, because that's an important aspect of our philosophy, and to promote that positive culture of engagement and learning and transparency. Next slide, please. This takes a team, and it takes a team that an organization is willing to invest in, which means the organization needs to see something from it from both a financial standpoint and a marketing and market share standpoint. So we started very early with myself and a half-time manager and one process improvement specialist and a data analyst on loan. And we have grown quite a bit. Full-time director, full-time manager, admin, and then 4 divisions that report up looking at clinical pathways, diagnostic safety. In order to really ensure you're doing the right care, you have to have the diagnosis correct. And that's a really big part of our program. Population management, and then we have regional care aspects of quality where we want to be able to work with our 7-state region on the right aspects of care. And then our work around process improvement specialists has really grown. We have a pathways program manager, a diagnostic safety program manager, and then divisions and units around the facility have invested in having a process improvement specialist embedded in our group, but dedicated to their particular service lines. So the emergency department has a specialist, the ICU and the hospitalist program share one, Breathing Institute, Digestive Health Institute share one. And then we have folks around population management and some senior level black belt process improvement specialists that take on large system-wide efforts. And then 2 dedicated data analysts. Next slide. So I'll start with the first case example around CAT scans and abdominal pain. One of the best ways I have found to really incent some of this work is when especially surgeons are at national meetings and they get embarrassed. So the slide on the left is a slide of what's called comparative data from NSQIP, or the National Surgery Quality Improvement Program in Pediatrics. And our organization in 2013 was identified as one of the highest abdominal CT utilizers in the country. So when the surgeons returned, they said, we've got to do something about this. And they pointed to us in the emergency department and said, you need to stop doing so many CT scans. And my response was, well, if we have an equivocal ultrasound, I'm pretty sure in 4 hours, you're going to tell me I need to do a CT scan. So instead of waiting 4 hours, I'm going to get that done. If you came at an earlier time and we worked together on a decision, maybe we could avoid some of that axial imaging. We had algorithms. We knew that we were putting these algorithms in a place where people hopefully could find it, but that's always a challenge as well. And so we had to take a different approach. The next slide will go back to, well, a static PDF of a guideline probably doesn't trump the culture of a particular institution. So we started with pulling together the emergency department, radiology, and surgery departments to agree on some aspects of what we were going to do. And as you can see under surgical consults, we asked them to respond promptly. And in fact, we made a deal that when the surgical consult would come down, they checked in at the actual desk in the ER, so we knew they were there. because they can be sneaky and come into a room, see a patient, and then scurry away. And that we were very, very, we asked our ED providers to not reflexively order a CT scan and to work with our surgical staff on this. We also changed some of the reporting aspects of imaging to, instead of saying a positive ultrasound or a negative ultrasound, we looked at reclassifying those into either high probability or low probability, because there are no perfect tests. And we were getting caught with negative ultrasounds that were coming back 3 days later with a perforated appendicitis. We ensured we knew exactly what we were going to do with particular aspects of rectal contrast, which has evolved over time. So the next slide will show you that back in 2013, we were indeed in that 40 to 50% range. And through our efforts, which we labeled Image Gently, we were able to then decrease that rate down to about 6.5%. And you can see that there's probably some special cause that occurred earlier. And one of the things that was happening is we were socializing this program. So the rumor got out that I was going to start sending our emergency providers their own personal rates of CT scan. And we did that. But even before those reports came out, people thought, oh no, I'm going to get graded on this. And as we know, providers are used to grades and they want to do well. Now, one of the things that happened is I got a call from the chief finance officer who said, hey, we still get paid for all those CT scans that you aren't doing. And I said, yeah, I know. And it's the right thing to do. And after a good conversation, it was, well, then we should do it. And we should figure out how to make sure that we do practice the right care, and we'll figure out the finances on the back. Now, this also requires real-time data. You need to be able to get data on your performance as it relates to your interventions in a timely way. And that was hard to do early on when, you'd wait 6 to 9 months for your data to come back. And then you go, oh, that didn't work. Or, oh, that is actually doing something. So we needed to partner very closely with our data and analytics folks to make sure that we were able to get that data in a timely way to inform our interventions. The next slide demonstrates that we've been sustainable. 6.5 was at the low end, so we've averaged now at about 10% axial imaging over the course of 2014 down to 2023, and you can see that curve. There are spikes. We've analyzed those spikes. When providers come from other institutions, when they're used to doing a certain practice, that they will repeat that practice, and we do ongoing educational work. We haven't had to do much ongoing educational work recently because as variation has narrowed, which is to me an indicator of hardwiring a system, we've been able to keep that sustainable and move on to other things, which is important. You cannot continue to utilize resources for one project because the resources aren't endless. So let's go to the next slide. It's really important to brand your initiatives because they need to be able to be absorbed by the organization in a way that you can communicate with one another. So I'm going to talk about bronchiolitis, which is the Rest is Best program. REST stands for Reduce Unnecessary Interventions, Educate the Team, Provide Supportive Care and Time, and have patience. Probably the two most effective interventions are t-shirts and water bottles. So people really do enjoy t-shirts. And it's a fabulous thing to be practicing in an ER when a nurse is wearing a Rest is Best t-shirt and you can hear the nurse educating the family in the room and coming to you and saying, I've suctioned that patient. I've taught the family how to do the nose Frida. They're looking much better. And when a patient looks better before a provider sees them, they are much less likely to order chest x-rays and order other things that are unnecessary. And the flip side is about high value care. We want to make sure that we are identifying our sickest patients promptly, and we are intervening to avoid bad outcomes and maximize our good outcomes. Sepsis was a big campaign for us and continues to be one of the major causes of morbidity and mortality in children. And so we've created campaigns, we've created mouse pads, we've created large learning aids within all of the trauma rooms and resuscitation rooms to help people manage this care and put it right at their fingertips. Next slide. Bronchiolitis, for the pediatricians in the room, we are very, very aware, and this sort of consumes our lives in the wintertime. A viral infection causing lower airway swelling, the most common cause of admission in children and infants. And this is old data, this cost is clearly over $2 billion, probably even more in our last respiratory surge. The next slide, please. And evidence is pretty clear, and that studies show chest x-rays are highly unlikely to demonstrate anything but an inappropriate, a likely viral infiltrate that will be misinterpreted as a bacterial infiltrate and lead to inappropriate antibiotic therapy. Using bronchodilators feels like it should be something that a wheezing patient would benefit from, but has never been shown to have a consistent benefit. So this was our driver to undergo this program. And this is a program that affects anywhere from 3,000 to 6,000 patients a year. That's how much bronchiolitis we see just at our institution. Next slide. After we went through a really, really rigorous scoping program through using our Lean Six Sigma tools, we achieved some pretty outstanding results where we were able to decrease patients receiving a bronchodilator down from 36 to 22%. We analyzed those spikes at the end of the season, looking at aspects of return visits, kids who wheezed previously in the season and then were wheezing again, oftentimes prompting more bronchodilator use. It's been an ongoing project. The next two slides will look at chest x-rays, so we can go to the next slide. And chest x-rays are really challenging to decrease. Pulmonary disease in a child is very worrisome. We have both providers as well as children, providers and parents, very concerned. Chest x-ray can be reassuring, even though it's never going to rule out anything, and it's not going to rule in anything that except something that may be inappropriately treated with antibiotics. However, there are some serious diagnoses that mimic bronchiolitis. That's why these numbers should never be driven to zero. You only know that a test was unnecessary at times after you've done it. So you have to be very confident in the evidence. You have to be confident in your clinical exam skills, and you have to be very confident that if the patient's not progressing as you would expect a patient to progress, you may need to reconsider your diagnosis, which is, again, that aspect of diagnostic safety. Now, we can look at the next slide, which is around respiratory viral testing, which we were doing great with until the pandemic. And the pandemic gave us a brand new virus to worry about. So that sort of changed things, and I will demonstrate that with the next slide, which again tells you that over time we can continue to measure and really focus in on where we are. Now you can see in that January 2020 period, the pandemic hit, everybody put masks on, no children weren't going to school, so viral transmission ceased. And this was a big aspect of our ability to get a hold of the pandemic before the vaccinations came through. But then you can see that huge spike last year. That was that RSV, COVID, flu, triple-demic. We saw more patients with respiratory disease than we have ever had in the history of this hospital, my time here for sure, which is now about 27 years. And it goes to show what happens when a group of children and a group of parents don't get exposed to a particular virus where immunity really does actually have an impact. We're hopeful that we don't see this kind of surge again. But we have returned now to really emphasizing where we were around how we are best managing patients with bronchiolitis. Next slide. The anchor around this, around clinical pathways, need to be highly accessible. About a decade ago, we put that little radio button that says clinical pathways right above our search bar in the main intranet site, and it takes you to all the pathways quickly. Next slide. But it needs to be external. Our primary care providers, who are essential in this process. And the reason I tell you that is not only do they need, obviously, pathways to help manage their patients, but they need to help parents understand what to expect when they go to the hospital. And because of those partnerships, to be able to care for a patient that says, our doc sent us in and we understand that, this is going to be about oxygen and respiratory support. We're probably not going to need a chest x-ray or a test to prove that the runny nose is actually a virus, et cetera. We actually have a much better collaboration. And other emergency departments. We want to make sure that our other emergency departments around the state, around the country who are seeing these patients have access to this information as well. The next slide starts to demonstrate where we try to put the best practice right at the provider workflow. For diabetic ketoacidosis, you can click and link straight from the pathway, but it takes you to a PDF. So we took some further steps with a partner of ours in the next slide, where we're now able to embed pathways right into the workflow, and you can order straight out of them, and it will hold your place. So when you go to the pathways in our EMR, you can click, open the pathway, and you can see the next slide where the links are now for the tests you need. You can click on them and it'll hold your place. And the next slide shows that you can sign them and then off you go. Procalcitonin, and the reason I bring this up is that fever in an infant is an extremely worrisome presentation. And we worry so much that we would get blood cultures, urine cultures, and spinal taps, because it's incredibly hard to risk stratify those patients. The evidence has shown that the use of procalcitonin, however, can really help you avoid the lumbar puncture. Now, I asked when I was in training 25 years ago to one of our ID attendings, I said, well, which babies actually need the lumbar puncture? And he said, the ones with meningitis. Well, you don't know that yet, right? And when only 0.5% of those patients is going to have meningitis, that's a lot of lumbar punctures. They're stressful on families. They can be hard sometimes. And we love the strategy of reducing those. So the next slide, this is about my plea to always partner close with your analytics team. But the next slide will show you that we were able to increase procalcitonin and start to really decrease lumbar punctures. And if we are able to take a cheaper blood test to avoid a more expensive, painful, and at times really anxiety-provoking spinal tap, I think we're doing the best to maximize high-value care and minimize, at times, the low-value care. Now, those return visits were during our respiratory surge, and we'd never seen that before in our careers, and hopefully never will again. The next slide. So when we compare ourselves against like institutions, we go to the Children's Hospital Association, a collection of many freestanding and pediatric hospitals within a system. And they were able to work on a set of criteria around low-value care in pediatrics, and then evaluate institutions on how they were doing with eligible encounters where they identified low-value care. And I'm proud to say that this was just published in 2023, that we're that light green bar. And I think what it demonstrates is that if you have really good partnerships, if you culturally are able to embed evidence in the workflow, work with your community partners, you can actually achieve some of these goals. We still have a long way to go, but it's important for us to be able to highlight some of this work, to continue to work with our payers, continue to work with our Medicaid partners, to know that, you know, we're a good place for their members to get care. Next slide. Yeah, celebrate your successes. It's a big part of what we do. None of myself and two of my team members, as we were celebrating at the Stanley, did not give consent for this photo, but you're in public, so you don't have to. But there we are, enjoying the fact that we work well together, we like each other, and the work is hard, but it is really rewarding work when you know that you can really start to make a difference for value for your patients and families. So that's my presentation. I'd be happy to have any conversation or questions, and you can always reach out to me as well. And Kristen, I'm not sure if you can always connect my email if people contact you and send them over to me if there's any conversation or questions.
Thank you, Lalit. That was fantastic, and congratulations on the progress that you've made. We have got the question and answer, or the chat box, open for questions. Some of you have entered in a couple questions which have been addressed throughout Dr. Bajaj's presentation. And I'd like to go ahead and open it up for folks to ask whatever questions you have for either our team, for Tim and Emma, or for Dr. Bajaj. As folks are entering those in, I might take presenters' prerogative and ask a question of my own. What's your next target? What are you focusing on next as far as reducing low value care over children's?
So some of the bigger efforts that we're looking at are partnered with some of our payers and our Medicaid payers to really look at length of stay, readmissions, depression, suicide screening, social determinants of health. Those are some of the bigger population management. We've done work on opioid prescribing. We've done work on a lot of initiatives that were really important for our organization. But the newest work is really to help our patients and families transition between care settings in the most valuable way. Nobody wants to be in the hospital if they don't have to be. And no one wants to be in the hospital longer than they have to be. So we really are focusing our energies on ensuring that our care coordination efforts are really well designed to help folks transition. And mental health, as we all know, and social determinants are huge drivers in health outcomes for families and kids. But it's hard on a system to be able to implement all of these kinds of strategies when we're designed to care for the kids' acute illnesses. And it feels like we're doing so much work that's outside the scope of what we are designed to do. But when society fails to invest in mental health, social determinants, and sort of pushes it into the medical arena, we have to respond. But we can't solve all the problems. So if we can start to do some of that work and screening and make sure that that information is communicated effectively to our primary care partners and to our other partners in the community, we will hopefully be able to get folks into the right resources and to be able to help folks who are struggling with food insecurity and housing security, et cetera, be able to care for their children now that we avoid readmission, avoid admission. I would much rather care for a child who's out playing soccer because their asthma is controlled and they're out exercising and oops, they fall and break their arm. Well, The emergency department's still there for you. But I would much rather have them be well and healthy and going to school and playing the sports they enjoy. And so those are some of the big efforts that we're undertaking.
That's great. And I mean, that's a key example of the importance of partnerships, making sure that you've got those partnerships and those ways to connect folks with the care they need outside of the hospital. We do have just one comment so far for you from Patricia Weber, just giving you kudos for a great job in reducing the ED department, ordering CTs for appendicitis and the other tests that you guys were able to address, target and address over time. Any other questions from the attendees for Dr. Bajaj or for our team? I know Tim has been addressing a question about the choosing wisely opioid measure, and then Emma's been addressing a question about the drill downs for various regions of the state. Again, these choosing wisely measures are available in large part online. As Tim mentioned, there are about 58 of them. They're all able to be addressed through the claims data, and you can get the details of those online. I would add, just in my experience with the choosing wisely recommendations, it does help to go into some of those specific in the specific descriptions around what it is that they are and are not recommending, because sometimes the high level title of a recommendation doesn't necessarily reflect what they're actually trying to reduce. And so I would recommend, if you've got questions about any of those, you really head to Choosing Wisely online and dive into those in a little bit more detail.
So I will just comment, just published, it came out in December, the very first pediatric emergency medicine list for Choosing Wisely. But what we're doing is we're packaging all of those with resources, including videos, podcasts, scripts for providers on how to talk to families about aspects of the care, because family expectations are a real driver. Sometimes I think we overestimate that driver and we say, well, they wanted it. That's maybe our bias versus actually having a conversation about the tests or interventions. But again, the implementation being complicated. Sending an email with a link as review is not an effective in and of itself. There really needs to be concerted, data-driven, and addressing folks' challenges. If you are in a high litigation environment, it is harder to minimize low-value care. We know that through a lot of the work we've done with colleagues in other parts of the country that live in a much more litigious environment. And so all those kinds of factors really need to be addressed. That can't be minimized in terms of risk tolerance and the ability for folks to feel like they can lower the test and treatment ordering and do it safely, and that the organizations and will basically support them.
Yeah, I think that's an important point. I'm sure it's especially critical in the pediatric environment. It's a very sensitive population. So a question from Alex Shackle, and I think this is probably Tim and Emma, this is probably for you guys primarily. So using the CIVIC database, would we be able to compare and review specific hospitals' data?
That's not available currently for the public reports. You can always contact CIVIC. We do build custom reports or custom extracts for individuals, but not right now using the publicly available data. And a lot of that has to do with volume issues. We have to make sure for publicly available data that there's the sufficient volume that nothing can be identifiable. But get in connection with CIVIC, and if it's needed, we can see what we can do.
Absolutely. Thanks, Emma. The database does have the capability of supporting hospital to hospital comparisons. Again, as Emma mentioned, depending on volume, but not available in the public on the public website. Just one more quick question for you, Lalit, before we end today. Related to what you were just discussing. I know you mentioned in your presentation that visibility and really baking in some of these efforts into the day-to-day experiences of your providers has been critical, but do you have any other recommendations for educating parents and educating families around the value of some of these efforts that may go against what they would have assumed their, what their child should be receiving?
Yeah, and I think that really is something that you have to do in concert with the community. By the time folks get to the hospital, it's probably a little too late, right? Because you're starting to have conversations that are complicated. You have worried parents and worried families, and their neighbor may have gotten a ton of tests, and that's what they're expecting. I do see my friend and colleague Hope Stapp on the call, who's the medical director of our pediatric care network. And I think we all know the importance of then having not just the pre-education of what might happen in the hospital, but when they go follow up, when sometimes people are frustrated, to be able to reinforce it, to be able to say, no, this is good, it's okay. We're going to get through this illness, following the right trajectory. And if things change, we can start to think about what other things may need to happen. But to me, that's there's pre, there's post, and then there's reinforcement. We actually put up banners where all our providers signed a pledge to minimize unnecessary testing, and we put it in our waiting rooms, so that folks would know that we take this very seriously. We're not trying to minimize how ill your child is, because as we all know, some people can leave the hospital and say they did nothing. And to say, well, we supported the child, and sometimes doing less is actually doing more. If I were, and I have, given an antibiotic at times when you're unsure, and that patient had an allergic reaction to that antibiotic that you didn't know was going to happen because they never got it. Certainly would have been nice to not have that happen, right? And we do know that and we saw it too with our chest x-ray rates going down, our antibiotic rates for these kids went way down. So those are some of the things that, we want to make sure we continue to analyze, but these are hard. And the pandemic changed a lot of it, because we had a new virus, we didn't know what it was going to do. And testing was also about epidemiology and surveillance. So we still have some more work to do that we weren't expecting.
Well, thank you, Lalit, for being with us. Thank you, Tim and Emma, for your time and walking through what you've created for Civic and for the public. And thank you, everyone, for joining us. This webinar will be available on the Civic website under Data to Drive Decisions. And I believe we'll be providing a link to the slides as well. I think we had that conversation right before the webinar started. So thank you, everyone, and enjoy the rest of your day.